Imagine for a second the immune system of a healthy adult encountering a severe viral threat. The alarm bells ring, the defenses mobilize, and there's just this brutal microscopic war.
Right. It's a very coordinated response.
Exactly. And eventually, well, in most cases anyway, the adult's immune system manages to force the invader into a corner. It achieves a kind of stalemate, pulling the viral load down to a manageable level.
Yeah, a set point.
Right. Now strip all those defenses away.
Oh, wow.
Just imagine a newborn, just days old. Their immune system is entirely naive. It's still trying to figure out which way is up. If that newborn encounters the exact same virus, there is no stalemate.
No, not at all.
The viral load rockets to hundreds of thousands, sometimes millions of copies per milliliter of blood by the time they are 2 months old.
Yeah.
And it just stays there.
Yeah.
Millions of copies circulating endlessly for an entire year.
It's a staggering biological reality. You're looking at a completely unguarded host facing this microscopic machine of just terrifying efficiency.
And that reality is the foundation of what we are unpacking today. We're taking you into the absolute center of the pediatric HIV landscape.
Right into the deep end.
Literally. We have a source text in front of us today that does not sugarcoat anything. It's a dense, rigorous clinical slide deck. It's titled MSL Pediatric HIV-2 Copy.pptx.
A very clinical title.
Yeah, very much so. This isn't a high-level summary. This is the unfiltered medical data used to understand, diagnose, and treat this virus on the front lines. And we are going to go through it line by line.
From the exact molecular architecture of the virus, all the way down to, how a clinician has to handle a newborn infant in the delivery room to prevent transmission.
Yeah, we want to equip you with the raw data. I'm going to act as the technical reader here, just giving you the numbers and the lists straight from the deck. But more importantly, we want to translate what those statistics actually mean when you are standing in a clinic in sub-Saharan Africa.
Because the numbers are daunting.
Yeah.
But understanding the mechanisms behind them, it gives us a profound perspective on how medical science is fighting back.
Absolutely. So let's start with the scale of this crisis. The epidemiology data in the text paints a picture that is, well, it's hard to wrap your head around. It states that HIV and AIDS are a major cause of infant and childhood morbidity and mortality in Africa.
Which we know, but the specific numbers really drive it home.
Yeah, specifically in children under 5 years old, the virus accounts for 7.7% of mortality worldwide.
Stop and think about that 7.7% figure for a moment.
It's massive.
It really is. When you consider all the things that can threaten a child under 5 globally.
Like malnutrition, malaria.
Diarrheal diseases, accidents. To have a single viral pathogen responsible for nearly 8% of all deaths in that age group is a massive demographic footprint.
Yeah.
The text highlights that back in 2007, AIDS was responsible for a 19% rise in infant mortality and a 36% rise in under 5 mortality rates.
Wow, 36%.
Right. It was literally reversing decades of public health progress in these regions.
And the geographic concentration is just as striking. The UMAIDS data from 2017 notes there were 1.8 million children under 15 years living with HIV globally. But then you look at the WHO estimation from 2013, which looked at 3.2 million children living with HIV-1, and it states that 90% of them were from sub-Saharan Africa.
90%. That concentration requires us to look at the structural realities of the region. Like, why is the burden so heavily localized?
The text points to a couple of specific things.
Yeah, it explicitly points to 2 intersecting factors.
Yeah.
High birth rates and high rates of mother-to-child transmission. It's a compounding effect.
Because they feed into each other.
Exactly. In regions with high fertility rates, any pathogen that utilizes vertical transmission passing from mother to child is going to experience an exponential multiplier. It leverages the very act of population growth to sustain itself.
And we see that multiplier clearly in the country-specific data. The text gives us a spectrum of prevalence in children aged 0 to 14. In Tunisia, it's 500 children. But then you jump to Nigeria with 220,000 children and South Africa with 280,000.
Yeah, the jump is just staggering.
And looking closely at Nigeria, which the text notes has the second highest burden globally with 3.4 million people living with HIV as of 2014, the human cost is devastating. Cumulative AIDS deaths hit 2.99 million.
Unbelievable.
And here is the statistic that really forces you to pause. 2.23 million Nigerian children have been orphaned by AIDS.
When you cross a threshold of over 2 million orphans in a single nation due to one disease, you are no longer just dealing with a public health crisis.
No, it's something entirely different.
You're looking at a profound social and economic destabilization. The loss of a generation of parents means the disruption of knowledge transfer. It's the collapse of household economies and an immense strain on extended family networks and state resources.
So the text does show a turning point, though, thankfully. It notes that the Nigerian national HIV prevalence actually dropped from a peak of 5.8% in 2001 down to 3.1% in 2014.
Which is a significant victory.
Yeah. And there is significant internal variation, too, from 0.3% in Katsina State all the way up to 5.5% in Akwa Ibom State. But the broader global turning point is the introduction of antiretrovirals, or ARVs.
The game changer.
Right. The text states that with the introduction of ARVs, survival increased, and by 2017, up to 940,000 children under 15 were receiving RT, which, by the way, was a jump from 640,000 just 5 years prior in 2012.
That jump to 940,000 children on treatment is the counter-narrative to that orphan crisis we just talked about. It represents a massive, coordinated logistical triumph.
I can't even imagine the supply chain for that.
Right. Getting nearly 1 million children onto complex daily medication regimens means setting up supply chains, cold storage, diagnostic labs, and training thousands of healthcare workers. It altered the survival trajectory of an entire demographic.
So let's talk about how the virus is actually moving through that demographic. The text states that in children, transmission is via the mother-to-child or vertical route, and that accounts for greater than 90% of transmission.
The vast majority.
But then it breaks down the timing. It can occur in utero at a rate of 5 to 10%, at delivery at 5 to 20%, or during breastfeeding, and the overall transmission rate without any medical intervention is 15 to 45%.
Which means if an HIV-positive mother receives no antiretroviral therapy, no specialized delivery care, and breastfeeds her infant, there is roughly a 1 in 3 chance the virus will be passed on.
You know, see, that 15 to 45% baseline transmission rate without intervention is actually really surprising to me.
How so?
Well, if a mother has the virus actively circulating in her bloodstream and the infant is literally connected to her blood supply for 9 months, wouldn't you intuitively expect the transmission rate to be much closer to 100%?
That's a very logical assumption, yeah.
So does this mean the placenta is actually acting as a highly effective filter for the other 55 to 85% of cases?
It absolutely does. The placenta is an incredibly robust biological barrier. It allows nutrients and oxygen to pass through while keeping the maternal and fetal bloodstreams largely separate.
That's amazing.
It is. That's why the text specifies that the in utero transmission rate is only 5 to 10%. The fetus spends 9 months inside a mother who may have a very high viral load, yet the vast majority of the time, the virus cannot cross the placental wall.
But then the delivery transmission rate jumps to 5 to 20%.
Right, because the mechanical act of childbirth changes the equation entirely. During labor, the placenta separates from the uterine wall. Uterine contractions create intense pressure, and there is a high likelihood of maternal and fetal blood mixing.
So the barrier breaks down.
Exactly. The physical trauma of birth is actually a more dangerous window for transmission than the entire 9 months of gestation.
And then there's the third window, breastfeeding. The text explicitly highlights that prolonged breastfeeding and mixed feeding are key factors responsible for higher transmission rates in Africa.
Yeah, let's unpack that.
It's estimated that one sero-exposed infant is born every 5 minutes in Nigeria, though the text notes this is declining with universal ARVs for pregnant women. But I want to focus on that phrase, mixed feeding.
This is a critical point of clinical counseling. Mixed feeding means giving an infant breast milk, but also supplementing it with water, other fluids, or solid foods before the age of 6 months.
Okay, so why is that so dangerous?
To understand why, you have to picture the lining of a newborn's gastrointestinal tract. It's extremely delicate, essentially just a single layer of cells.
Wow, just one layer.
Yeah, if an infant is exclusively breastfed, the milk actually coats and protects that lining. But if you introduce water, which by the way might contain local pathogens or rough solid foods, it can cause microabrasions and inflammation in the infant's gut.
So it damages the mucosal barrier.
Exactly. It
Yeah.
creates these microscopic wounds in the gut lining. So if the infant is then given breast milk containing the HIV virus, that virus suddenly has a direct, open portal of entry straight into the infant's bloodstream.
That makes so much sense.
Yeah, that is why mixed feeding drastically increases the transmission risk compared to exclusive breastfeeding.
Aside from vertical transmission, the text briefly mentions other modes, like sexual contact, blood transfusions, and contaminated sharps. But it makes it clear the vast majority is mother-to-child.
Right.
To understand how the virus exploits those microscopic wounds in the gut, we need to zoom in. The text provides a really rigorous structural breakdown of the biological architecture and pathogenesis of the virus.
Yeah, let's look at the blueprint of the invader.
The text states the virus belongs to the lentivirus group of retroviruses. The mature genome of HIV is diploid, meaning it has two identical positive sense single-stranded RNA copies.
Okay.
It has an outer double-lipid membrane, or envelope, lined by a matrix protein called P17.
Let's try to visualize that. It's essentially a microscopic sphere. The outer double lipid membrane is actually stolen from the human cell it previously infected.
Wait, stolen.
Yeah, it literally wraps itself in a piece of human cell membrane as camouflage as it leaves.
That is devious.
It's incredible. Just believe that stolen lipid membrane is the P17 matrix protein, which acts like a structural scaffolding to hold the sphere's shape. And deep inside, holding the genetic instructions, are those two strands of RNA you mentioned.
And the surface of that outer membrane is studded with what the text calls glycoprotein spikes. For HIV-1, these are GP120 and GP41. For HIV-2, they are GP105 and GP36. And those spikes surround a cone-shaped protein core inside the virus, known as P24.
The distinction between the surface glycoproteins is what differentiates the two main types of the virus.
Right.
HIV-1, utilizing GP120 and GP41, is the driver of the global pandemic. The text notes that subtype B is prevalent in Western Europe and North America, but that all subtypes are found in Africa, with the AG recombinant being most predominant in West Africa.
And HIV-2.
HIV-2, which uses GP105 and GP6, is geographically restricted. It's mainly found in West Africa, Mozambique, and Angola.
Is the difference just geographic, or do those different glycoproteins change how the virus behaves in the body? Oh, they change its behavior significantly. Because of the different structural binding of HIV-2, it causes a much less severe clinical illness.
Interesting.
Yeah, it's less efficient transmission. In fact, the mother-to-child transmission of HIV-2 is quite rare, and it shows a much slower, less aggressive disease progression compared to HIV-1. But whether it's type 1 or 2, that cone-shaped P24 core you mentioned, that is the payload.
The core.
Right? It houses the viral RNA and 3 highly specialized enzymes.
And the text lists those 3 viral enzymes explicitly. First, reverse transcriptase, which converts viral RNA into double-stranded DNA. Second, integrase, which causes the integration of that double-stranded DNA into the host's own DNA.
Yeah.
And third, protease, which splits generated macroproteins into smaller viral proteins so they can be incorporated into new viral particles.
Those 3 enzymes are the engine of pathogenesis.
Yeah.
And they operate in a very specific sequence. To understand their sequence, we have to look at their target.
The text outlines the target precisely. HIV-1 primarily targets the CD4 plus molecule on T helper cells. The virus uses its GP120 and GP41 spikes to bind to the CD4 plus receptors, along with chemokine co-receptors named CCR5 and CXCR4.
Picture a lock and key mechanism. The CD4 receptor on the human T helper cell is the lock. The viral GP120 spike is the key.
Okay, simple enough.
But to fully open the door, the virus also needs to turn a second lock, the co-receptor, either CCR5 or CXCR4. Once it binds to both, the viral envelope fuses with the human cell membrane, and the virus dumps its cone-shaped P24 core inside.
And that is when the 3 enzymes go to work.
Exactly. Enzyme number 1, reverse transcriptase, takes the viral single-stranded RNA and builds a double-stranded DNA copy of it. This is a backward step in biology, by the way.
Because normally it goes the other way.
Right. Normally DNA makes RNA,
Right.
but this is a retrovirus, so it works in reverse. Then enzyme number 2 integrates, grabs that newly minted viral DNA, carries it into the human cell's nucleus, cuts open the human's own DNA strands, and stitches the viral DNA right into the host's genetic code.
The text notes something profound about this integration. It says the virus continues to reside there indefinitely as a provirus.
It becomes a permanent part of the host. The cell is forever altered. Whenever that human cell naturally activates and reads its own DNA to make proteins, it also reads the viral DNA.
So it's tricking the cell.
Completely. The cell unknowingly manufactures long, raw chains of viral proteins. That's where enzyme number 3, protease, comes in.
Right, the protease.
Protease acts like a chemical pair of scissors. It cuts those long, useless macroprotein chains into the precise, functional, smaller proteins needed to assemble a new virus. The new virus particle assembles, buds off the human cell membrane, stealing a piece of it on the way out like we talked about, and goes off to infect the next cell.
And the cost to the host cell is just absolute. The text lists the vital roles of the CD4 plus cells that are subsequently lost due to this progressive destruction. It's a cascading failure across the entire immune system.
Let's hear the list.
The lost roles include maturation of B cells to plasma cells to make antibodies, the induction of natural killer or NK cells to destroy tumor cells, the activation of macrophages for efficient phagocytosis, the suppression of other T and B cells by CD8 plus suppressor T cells, and the lysis of infected cells by cytotoxic CD8 plus T cells.
That list perfectly illustrates why the CD4 cell is often called the general of the immune system. The virus isn't just taking out frontline soldiers, it is taking out the command and control center.
It's decapitating the immune system.
Exactly. Think about what those lost roles mean in practice. If B cells can't mature into plasma cells, the child cannot produce antibodies to fight off new infections. If macrophages aren't activated for phagocytosis, they aren't eating the bacteria that constantly enter our lungs and gut.
And the loss of the natural killer cells. The text specifies their role is to destroy tumor cells. So does that explain why certain cancers become so prevalent in AIDS patients?
Yes, absolutely. Our bodies are constantly producing abnormal cells that could become cancerous. But our natural killer cells routinely hunt them down and eliminate them before they multiply.
Like a patrol.
Right. When the virus disables the CD4 generals, the NK cells don't get the signal to attack. The surveillance network goes dark. That is why the loss of CD4 cells leads directly to an increased incidence of tumors. The text notes that the continuous viral replication leads to progressive CD4 cell destruction, which ironically triggers the body to produce more CD4 cells to replace them.
Which just gives the virus more targets.
Precisely. It's essentially throwing fresh troops into a meat grinder, providing more targets for the virus until the system completely collapses.
And this collapse leads us to the natural history of the disease and what happens when this biological mechanism is unleashed in a child versus an adult. The text points out a stark contrast in the viral trajectories.
Yeah, this is key.
In adults, following primary infection, the CD4 count decreases and HIV RNA rises. But then the viral load typically declines to an equilibrium known as a virologic set point within 6 to 12 months.
Right. In an adult, the initial massive spike in viral load triggers a robust counterattack by cytotoxic T lymphocytes. They start hunting down the infected cells. It's a brutal fight, but within half a year to a year, the adult immune system manages to suppress the viral replication down to a plateau. That set point.
It doesn't cure it, though.
No, it doesn't clear the virus, but it manages the sheer volume of it, delaying the progression to AIDS for years.
But the text says viral load trends in perinatally infected infants differ vastly. In infants, viral load levels are low at birth. Then they increase to levels greater than 100,000 to millions of copies per milliliter by 2 months of age.
Millions.
And critically, they remain at that exact same astronomical level throughout the entire first year of life, only declining slowly over the next few years to a set point.
This goes back to the scenario we discussed at the very beginning. An infant's immune system is incredibly immature. Their cytotoxic T lymphocyte response simply does not possess the memory or the strength to mount that robust counterattack.
They just don't have the troops.
When the virus hits, it encounters almost zero resistance.
Is it purely that their immune system is naive, or is there something about the physical state of infancy that makes it worse?
It is the combination of a naive immune system and rapid cellular growth. An infant is growing at an incredible rate, which means their body is constantly manufacturing millions of fresh, susceptible CD4 cells.
Oh, wow.
They're essentially providing a limitless buffet for the virus. The virus replicates unchecked, reaching those millions of copies by month 2, and the infant's body cannot establish a set point to pull it down.
This brings up a critical diagnostic nuance from the text regarding how we measure the damage. In adults, we often talk about the absolute CD4 count, but the text states that in children, the absolute CD4 plus count varies wildly with age.
Very wild.
It is naturally very high in healthy infants and slowly declines to adult levels by 6 years of age. Therefore, the absolute count is not the best metric.
Right, it's misleading.
Instead, the text insists that the CD4 percentage does not change with age. And that is a preferred parameter for monitoring disease progression in children 5 years and under.
This is a vital distinction for any clinician. Because an infant's overall white blood cell volume is naturally so high, an absolute CD4 count might look perfectly fine on paper. You might see a number that would mean an adult is healthy, but it's an illusion created by the sheer volume of cells.
So you have to look at the ratio.
Exactly. If you look at the CD4 percentage, meaning of all the lymphocytes present, what fraction are actually CD4 cells, you see the true devastation. The total number of cells might be high, but the proportion of CD4 generals is plummeting.
The text provides the exact thresholds where the risk of AIDS or death sharply rises based on that percentage. The risk rises when the CD4 percentage falls to less than 25% in infants, less than 20% in children from 1 to 3 years old, and to less than 15% in children 3 years and older.
Hitting those percentage thresholds means the command center is officially compromised. The immune system is teetering on the edge of failure.
And the speed at which that failure happens dictates the child's survival trajectory. The text categorizes disease progression in African children into 3 distinct groups. Category 1 accounts for 25 to 30% of cases.
And these are the fast progressors.
Right. These are diseases acquired in utero or perinatally, characterized by rapid disease progression and death within the first year of life.
Category 1 is the most tragic outcome of the infant viral load dynamics we just discussed. Without intervention, nearly a third of all perinatally infected children will not live to see their first birthday. The sheer volume of the virus simply overwhelms them before their immune system can even attempt to establish a set point.
Category 2 is the largest group, accounting for 50 to 60% of cases. These children develop symptoms early in life, slowly deteriorate, and die by 3 to 5 years of age.
Okay.
And then Category 3 accounts for 5 to 25% of cases. These are the long-term survivors who may live beyond 8 years of age without therapy.
The variability there, from rapid progression in months to survival beyond 8 years, depends on several overlapping factors.
The text actually lists out the specific factors predicting disease progression. Infant factors include the initial infecting viral dose, maternal viral load, infection occurring before 4 months of life, a high infant peak viremia, rapid decline in CD4 percentage, the onset of clinical AIDS, and something called P24 antigenemia.
The initial infecting dose is critical. If a child receives a massive influx of the virus during delivery, they are much more likely to fall into that rapid progressing Category 1.
And what about that last term, P24 antigenemia?
The P24 antigenemia you mentioned means the physical core protein of the virus is detectable in high concentrations in the blood. It indicates massive, uncontrolled viral replication.
Got it. It also lists maternal factors that accelerate the child's disease progression. These include a high maternal viral load at the time of delivery, a maternal CD4 plus count of less than 200, rapidly progressive maternal disease, and maternal death.
Think about the biological intimacy here. The child's immune trajectory is inextricably linked to the mother's immune failure. If the mother's CD4 count is below 200, she is in an advanced state of AIDS. She has no control over the virus, meaning the viral load she exposes the infant to during delivery or breastfeeding is astronomical.
Speaking of breastfeeding, the text goes even deeper into the specific transmission risk factors there. It lists maternal factors like mastitis, breast abscesses, and cracked nipples, and infant factors like oral lesions.
We touched on this with mixed feeding, but the physical reality of these specific factors is just brutal.
Yeah.
Mastitis is an inflammation of the breast tissue, often involving an infection. Cracked nipples and breast abscesses mean there is actively bleeding tissue. If a mother has these conditions, the infant is no longer just ingesting breast milk, they are ingesting raw maternal blood with a high viral titer.
Wow.
And if the infant has oral lesions, perhaps from thrush, that blood bypasses the mucosal defenses entirely and enters directly into the infant's circulatory system.
The text also lists other maternal risk factors that increase transmission risk. A high overall viral load, the presence of sexually transmitted infections, acquiring a new HIV infection during pregnancy, advanced disease, antepartum hemorrhage, premature rupture of membranes, prolonged labor, invasive delivery procedures, episiotomies, and breast conditions.
That's quite a list.
It is. Fetal risk factors include prematurity and being the first of twins delivered vaginally.
The mechanical factors of labor on that list are all about exposure time and trauma. Premature rupture of membranes means the protective amniotic sac breaks early, exposing the fetus to the viral environment of the birth canal for a prolonged period before they are even born.
Makes sense.
Prolonged labor, invasive procedures like using forceps or episiotomies all increase bleeding and tissue trauma, creating more opportunities for maternal-fetal blood mixing.
And what about the new infection during pregnancy part?
Acquiring a new infection during pregnancy is exceptionally dangerous. When a person is first infected with HIV, before their immune system mounts a defense, their viral load spikes massively. If a mother goes through this acute primary infection spike while pregnant, the infectious dose she passes to the fetus is catastrophic.
Once a child is infected, clinicians have to know how to recognize the progression of the disease. This takes us to Section 4, the WHO clinical staging.
This is crucial for diagnostics.
The text provides exhaustive lists of how the disease physically manifests in infants, children, and adolescents.
This is where we move from the microscopic architecture to what a healthcare worker actually sees when a child walks into a clinic. In many resource-limited settings, you might not have immediate access to a lab to run a CD4 percentage.
So they have to rely on symptoms.
Right. The WHO staging allows a clinician to observe physical symptoms, specifically opportunistic infections, and deduce exactly how badly the child's immune system has degraded.
Let's read through the general clinical manifestations first. The text lists fever, persistent generalized lymphadenopathy, respiratory illnesses like pneumonias and otitis media, malnutrition, and gastrointestinal conditions like diarrhea and parotid enlargement. But then it notes that some manifestations are very specific to HIV infection. These include pneumocystis pneumonia, esophageal candidiasis, extrapulmonary cryptococcosis, invasive salmonella infection, herpes zoster or shingles, Kaposi sarcoma, lymphoma, progressive multifocal leukoencephalopathy, and lymphoid interstitial pneumonitis.
That distinction is the cornerstone of clinical diagnosis. The first list, fever, diarrhea, otitis media, or ear infections, these are ubiquitous. They're the background noise of pediatric health in developing nations. Uninfected children get ear infections and diarrhea all the time.
Sure.
But that second list, those are the red flags.
Because healthy children don't get them.
Exactly. Pneumocystis pneumonia, or PCP, is caused by a fungus that is extremely common in the environment. A healthy child inhales it, their immune macrophages eat it, and they never even notice.
It's just handled.
Handled instantly. If a child develops a severe pneumonia from that fungus, it means their macrophages are entirely offline because the CD4 cells have been destroyed. The same goes for Kaposi's sarcoma, a cancer caused by human herpes virus, or esophageal candidiasis, which is a severe fungal infection coating the swallowing tube. These pathogens only cause disease when they are taking advantage of a completely unguarded host.
The text also points out features that are common in HIV-infected children, but not common in uninfected children. These include persistent or recurrent oral thrush, bilateral painless parotid enlargement, which means swollen salivary glands on both sides of the face of hepatosplenomegaly in non-malaria areas, and persistent generalized dermatitis unresponsive to treatment.
Those are the physical clues that prompt a clinician to order an HIV test, even if the child doesn't have a severe opportunistic infection yet. A child presenting with swollen salivary glands and a stubborn skin rash that won't respond to normal steroid creams is demonstrating a dysregulated immune system.
The text organizes all of these clues into the formal WHO clinical staging system, ranging from stage 1 to stage 4.
Let's break those stages down.
Stage 1 is the least severe. It includes children who are asymptomatic or those with persistent generalized lymphadenopathy,
which is just persistently swollen lymph nodes.
Stage 2 indicates mild disease. It includes unexplained persistent hepatosplenomegaly, papular pruritic eruptions, extensive wart virus infection, extensive molluscum contagiosum, recurrent oral ulcerations, unexplained persistent parotid enlargement, linear gingival erythema, herpes zoster, recurrent or chronic upper respiratory infections, and fungal nail infections.
Notice what is happening in stage 2. You are seeing the viral suppression of the immune system manifest primarily on the skin and mucosal surfaces.
Warts, ulcers.
Extensive warts, fungal nail infections, recurrent oral ulcers. The immune system is struggling to control common skin pathogens. The barrier defenses are weakening, but systemic collapse hasn't happened yet.
But stage 3 marks advanced disease. The criteria here become much more severe.
Yeah, this is where it turns.
It includes unexplained moderate malnutrition not adequately responding to standard therapy, unexplained persistent diarrhea for 14 days or more, unexplained persistent fever above 37.5 Celsius for longer than 1 month,
A fever for a month.
persistent oral candidiasis after the first 6 weeks of life, oral hairy leukoplakia, lymph node tuberculosis or pulmonary tuberculosis, severe recurrent bacterial pneumonia, acute necrotizing ulcerative gingivitis, unexplained anemia with hemoglobin under 8 grams per deciliter, neutropenia under 0.5, or chronic thrombocytopenia under 50. Symptomatic lymphoid interstitial pneumonitis, and chronic HIV-associated lung disease, including bronchiectasis.
When a child enters stage 3, the systemic breakdown is obvious. A fever lasting more than a month, diarrhea lasting more than 2 weeks. The body is in a state of chronic, profound inflammation.
And TB shows up here too.
Right, notice the appearance of tuberculosis. TB is an aggressive pathogen on its own, but HIV and TB have a lethal synergy. The HIV destroys the macrophages needed to contain the TB bacteria in the lungs, allowing the TB to activate and spread rapidly.
That's a devastating combination.
And the hematological issues you read, severe anemia and neutropenia, show that the virus is impacting the bone marrow's ability to produce new blood cells.
And then we reach stage 4, severe disease. The list here is a catalog of absolute immune failure. It includes unexplained severe wasting, stunting, or severe malnutrition not responding to standard therapy. Pneumocystis pneumonia,
There's PCP again?
recurrent severe bacterial infections such as empyema, pyomyositis, bone or joint infections, or meningitis, chronic herpes simplex infection for more than 1 month, esophageal candidiasis, extrapulmonary tuberculosis, meaning the TB has spread outside the lungs, Kaposi sarcoma, cytomegalovirus infection, particularly CMV retinitis, with onset at an age older than 1 month, central nervous system toxoplasmosis, HIV encephalopathy, extrapulmonary cryptococcosis, disseminated non-tuberculous mycobacterial infection, progressive multifocal leukoencephalopathy, chronic cryptosporidiosis, disseminated endemic mycosis like histoplasmosis, cerebral or B-cell non-Hodgkin lymphoma, and symptomatic HIV-associated nephropathy or cardiomyopathy.
Stage 4 is the clinical definition of AIDS. Every defense mechanism has fallen. The pathogens listed here: toxoplasmosis in the brain, cytomegalovirus infecting the retina and causing blindness, cryptococcosis. These are severe, life-threatening, opportunistic infections. The command center is gone. The virus has completely disabled the CD4 command center, and the environmental pathogens are running rampant. You also see the direct effects of the virus on the organs themselves, like HIV encephalopathy causing brain damage and developmental regression, or cardiomyopathy, where the heart muscle begins to fail.
I want to focus on a specific phrase that appears in both stage 3 and stage 4 regarding malnutrition. Stage 4 lists severe malnutrition not responding to standard therapy.
Yes, that phrase is critical.
In a clinical setting in sub-Saharan Africa, where you might have a high baseline of food insecurity, how difficult is it to untangle what is caused by poverty versus what is caused directly by the virus?
That is one of the most agonizing diagnostic challenges. A child presenting with severe wasting or stunting could simply be a victim of profound environmental starvation. That is why the WHO staging relies on that crucial qualifying phrase, not responding to standard therapy.
Because if it's just starvation,
If a clinician brings a severely malnourished child into a specialized feeding program, provides them with high-calorie, nutrient-dense therapeutic food, and the child still fails to gain weight or continues to waste away, it's a massive red flag.
the food isn't working.
It tells the clinician that the malnutrition isn't just a lack of calories. The HIV virus is inducing a severe metabolic derangement. The child's body is in a state of hyperinflammation, burning through massive amounts of energy, just trying to sustain the immune system's losing battle, while simultaneously suffering from persistent diarrhea that prevents them from absorbing any nutrients they do consume.
To confirm exactly what is driving that systemic failure, clinicians have to move from physical staging to the testing algorithm. The text breaks down the laboratory diagnosis protocols in Section 5.
Right, the lab tests.
It outlines 2 broad categories of tests, antibody tests and virology tests. And it provides a very strict rule right at the beginning. Antibody detection is reliable in children above 18 months of age, but antibody tests are unreliable for HIV diagnosis in children under 18 months. For those infants, DNA PCR is diagnostic.
The reason behind that strict 18-month rule is one of the fundamental mechanics of mammalian pregnancy. During the 3rd trimester, a mother passes her own IgG antibodies across the placenta into the fetus.
It's like a temporary shield.
Exactly. It's an evolutionary defense mechanism to give the newborn a temporary immune shield while their own system develops. If the mother is HIV positive, she passes her HIV antibodies to the baby.
So if you run a standard rapid antibody test on a 4-month-old,
It will very likely come back positive. But it does not mean the baby is infected. It just means the mother's antibodies are still circulating in the baby's bloodstream. It can take up to 18 months for those maternal antibodies to naturally degrade and clear from the infant's system. Therefore, you cannot use an antibody test to diagnose a child under a 1.5 years old.
Which is why the text mandates virology tests for infants. It lists 3 specific types. First, the DNA PCR, which uses a dried blood spot, or DBS, sample. Second, the RNA PCR, which measures the plasma viral load and monitors disease progression. And third, the P24 antigen test.
Okay, let's break those down.
The text notes the P24 test is very specific for detection of core antigen during the early stage of infection, known as the window period, though a negative result does not definitively rule out infection.
Think about the difference between looking for footprints versus looking for the thief.
Oh, I like that analogy.
An antibody test looks for the immunological footprint left behind by the virus. But as we established in an infant, those footprints might just belong to the mother. The DNA PCR test is a virology test. It is looking for the actual thief.
The virus itself.
Specifically, it is looking for the viral blueprint, that provirus DNA that the integrase enzyme stitched into the host cell's nucleus. If a DNA PCR test finds that genetic sequence in a baby's blood cells, it is definitively diagnostic, regardless of maternal antibodies.
And the RNA PCR.
The RNA PCR looks for the free-floating viral copies circulating in the plasma. It measures the volume, the viral load. You use the DNA PCR to ask, is the virus present? You use the RNA PCR to ask, how fast is it replicating?
The text also mentions the window period and the P24 antigen test.
Right. When a person is first infected, there is a delay, a window period, before the immune system manages to produce detectable antibodies. During this window, the virus is replicating rapidly, and the cone-shaped P24 core proteins we discussed earlier are present in high concentrations in the blood.
So the test catches the protein itself.
Yes, the P24 antigen test can detect the physical pieces of the virus during this blind spot.
Knowing all these testing mechanics, the text provides the exact testing protocol for HIV-exposed infants under 18 months. It is a highly regimented sequence.
Walk us through it.
First, test at birth, specifically between 0 to 3 days old.
Okay.
If that is negative, do a NAT testing or DNA PCR at 6 to 8 weeks of age.
Checking again.
If that is positive, start ART immediately. If it is negative, continue monthly follow-up. If the child remains asymptomatic, do a rapid HIV test at 9 months. If positive at 9 months, do a NAT testing PCR to confirm. If negative at 9 months, continue follow-up and retest with a rapid test 12 weeks after the complete cessation of breastfeeding to confirm discharge from the PMTCT program.
That algorithm is meticulously designed to catch the virus at every possible transmission window. Testing at birth looks for in utero transmission. The test at 6 to 8 weeks looks for transmission that occurred during the trauma of delivery. The rapid test at 9 months starts looking to see if the maternal antibodies are fading and if the child has produced their own.
But the text also includes a crucial mandate regarding breastfeeding. It says, all exposed babies who are breastfeeding should get 2 DNA PCR tests. If the initial DNA PCR is negative, testing should be repeated 12 weeks after cessation of breastfeeding, irrespective of the method of feeding.
This is perhaps the most critical safety net in the entire protocol. Even if an infant tests negative at birth, negative at 6 weeks, and negative at 9 months, if that child is still receiving breast milk, they are actively being exposed to the virus every single day.
So they aren't clear yet.
Not at all. The protocol demands that the clinician must wait a full 12 weeks after the infant has consumed the absolute last drop of breast milk before running the final test. That 12-week buffer guarantees that you are well past any window periods from a late exposure during the weaning process. Only then can you safely declare the child uninfected.
If the tests do come back positive at any stage, we enter the most complex part of clinical management. Section 6, Therapy, or ART. The text makes it clear that antiretroviral therapy is lifelong.
A lifelong commitment.
The major goals are to stop and reverse disease progression, improve the quality of life, promote normal growth and development, and achieve an optimal response with minimal drug toxicity.
Notice the shift in the eligibility criteria the text provides here.
Yes, the eligibility criteria is remarkably broad. It states, ART should be initiated in all children with HIV, regardless of WHO clinical stage or CD4 cell count.
Regardless.
It does list priorities, though. As a priority, ART should be initiated in all children under 2 years. All children under 5 years with WHO clinical stage 3 or 4 disease or a CD4 percentage less than 25%. And all children 5 years and older with WHO clinical stage 3 or 4 disease or a CD4 count less than 350.
Historically, medicine used to wait. Clinicians would monitor the CD4 count and only start the heavy, toxic antiretroviral drugs when the immune system started to fail. But the modern mandate the text lays out is universal immediate treatment, regardless of clinical stage or CD4 count.
Just hit it right away.
The goal is to aggressively suppress the viral replication before it ever has a chance to degrade the immune command center, particularly in children under 2 who are at risk of that terrifying Category 1 rapid progression.
But the rules for building a treatment regimen are strict. The text states, there must be not less than 3 drugs from at least 2 classes used in a HART regimen.
HART stands for Highly Active Antiretroviral Therapy. The requirement for 3 drugs from at least 2 different classes is fundamental to outsmarting the virus.
Why 3 drugs, though?
Because reverse transcriptase is an incredibly sloppy enzyme. As it converts RNA to DNA, it makes constant mistakes, meaning the virus mutates at a staggering rate. If you give a child only one drug, the virus will randomly mutate a resistant strain within weeks, and that drug will become useless forever.
It just adapts around it.
Exactly. By hitting the virus with 3 different chemical weapons, attacking different parts of its life cycle simultaneously, you mathematically corner it. The odds of the virus randomly mutating resistance to 3 different mechanisms at the exact same time are astronomically low.
Let's break down those mechanisms. The text lists 7 distinct drug classes and their modes of action.
Let's hear them.
First, NRTIs, or nucleoside reverse transcriptase inhibitors. The text says they incorporate into viral DNA to stop replication and form incomplete viral DNA. Examples include zidovudine, or AZT, lemivudine, or 3TC, stavudine, D4T, abacavir, ABC, and emtricitabine, FTC.
Okay, that's class 1.
Second, NTRTIs, or nucleotide reverse transcriptase inhibitors. They act at the same stage but do not require phosphorylation. The main example is tenofovir, or TDF. Third, NNRTIs, or non-nucleoside reverse transcriptase inhibitors. They stop viral replication by binding directly to reverse transcriptase. Examples include nevirapine, NVP, and efavirenz, EFV.
Let's visualize those first 3 classes as they all target the exact same enzyme, reverse transcriptase.
Okay, the builder.
Imagine reverse transcriptase is a builder constructing a brick wall, the new viral DNA chain. NRTIs like AZT and 3TC are defective bricks. The builder grabs an AZT molecule thinking it's a normal cellular building block and places it into the wall.
But it's broken.
Right. The AZT molecule lacks the chemical hook needed to attach the next brick. The construction halts instantly. The DNA chain is terminated.
And the NTRTIs.
The NTRTIs, like tenofovir, are also defective bricks. They are just chemically pre-activated so they can be incorporated faster. But the NNRTIs, like nevirapine and efavirenz, work completely differently. They don't pretend to be bricks. They act like a chemical wedge that binds directly onto the builder's hand, physically jamming the reverse transcriptase enzyme so it can't move or function at all.
The remaining 4 classes target other parts of the cycle. Fourth, fusion inhibitors. They prevent HIV from initially infecting the CD4 T cells. An example is enfuvirtide.
Blocking the door.
Fifth, protease inhibitors, or PIs. They act at the last stage of the HIV cycle, preventing the assembly and release of functional HIV particles. Examples include lopinavir-ritonavir, LPVR, and atazanavir. 6. CCR5 inhibitors. They prevent the virus from attaching to the specific CCR5 co-receptors on the cell surface. An example is Maraviroc. And 7th, integrase inhibitors. They prevent the insertion of the viral DNA into the host's human DNA. Examples are raltegravir, RAL, and dolutegravir, DTG.
Protease inhibitors are incredibly powerful. Remember, protease is the chemical scissors that cuts the raw viral proteins into functional pieces just before the new virus buds out of the cell. If you introduce a protease inhibitor like lopinavir, the scissors are glued shut.
So the cell still makes the virus.
The cell still produces the virus particle, and it still buds off, but because the internal proteins were never cut and arranged properly, the resulting virus is an immature, non-infectious dud. And integrase inhibitors like dolutegravir stop the virus from ever weaving its blueprint into the host's DNA in the first place.
Using these building blocks, the WHO recommends preferred first-line regimens based on age. For neonates, it is AZT plus 3TC plus RAL. For children, it is ABC plus 3TC plus DTG. For adolescents, it is TDF plus 3TC or FTC plus DTG.
Notice how each of those regimens perfectly follows the Hart rule. Take the regimen for children. Abacavir and NRTI plus lamivudine, another NRTI plus dolutegravir and integrase inhibitor.
That's 3 drugs, 2 classes.
Exactly. You hit the reverse transcriptase with defective bricks, and you simultaneously block the integrase from altering the host nucleus.
But the text immediately follows these regimens with a daunting list of primary toxicities and adverse reactions for these drugs. The clinical reality of managing these medications in a growing child is severe.
It's a very fine line to walk.
For AZT, it lists hematologic issues like anemia, progressive macrocytosis, neutropenia, and thrombocytopenia, as well as myopathy. It issues a strict warning for severe anemia, change to D4T or transfuse. Do not use if hemoglobin is under 7.
The mechanism behind these toxicities is that these drugs are systemic. An NRTI like AZT is designed to trick the viral reverse transcriptase into using a defective building block. But sometimes the rapidly dividing human cells in the child's bone marrow accidentally grab the AZT molecule while trying to replicate their own cellular DNA.
Oh, so it halts human cell growth too.
Yes. It suppresses the bone marrow's ability to produce red blood cells, leading to severe, life-threatening anemia. That is why the text mandates pulling the drug if hemoglobin drops below 7. You are constantly balancing the toxicity of the drug against the lethality of the virus.
The toxicities for the other drugs are just as intense. For 3TC, the risks are pancreatitis, liver toxicity, and mild peripheral neuropathy. For D4T, it causes peripheral neuropathy, lipodystrophy, lactic acidosis, and hepatitis.
Severe metabolic effects.
For ABC, or abacavir, the primary risk is a severe hypersensitivity reaction. The text emphasizes that if it occurs, the clinician must not restart the drug, and patients should carry a notification card.
It's a life-threatening allergy.
For NVP, nevirapine, the risks are also hypersensitivity reactions and Stevens-Johnson syndrome. For EFV, efavirenz, the toxicities affect the central nervous system, specifically listing nightmares and psychosis. And for TDF, tenofovir, the risks include a drug rash, potential renal toxicity, and a potential decrease in bone density. The text strictly states, not for children less than 8 years old or with existing renal damage.
This list reveals the sheer logistical tightrope of pediatric HIV care. Abacavir can trigger a systemic, fatal allergic reaction. Efavirenz easily crosses the blood-brain barrier, leading to profound psychiatric side effects. Imagine trying to ensure a frightened toddler adheres to a strict daily medication schedule when that medication induces psychosis and terrifying nightmares.
It's heartbreaking.
And the warning on tenofovir is purely structural. TDF interferes with kidney function and bone mineralization. In a fully grown adult, clinicians monitor this risk. But a child under 8 is rapidly growing. Their skeleton is actively calcifying. If you introduce a drug that leaches bone density during that critical developmental window, you can cause permanent skeletal deformities.
Which is why they switch regimens as they age.
That is exactly why the WHO preferred regimen shifts from abacavir for children to tenofovir only once they reach adolescence.
Because of these extreme variables, the routine monitoring on ART is intense. The text requires clinic visits every 2 weeks for the first month, monthly for 6 months, then every 3 months thereafter. And crucially, it mandates checking dosages for every 10% change in body weight.
That weight check mandate is the most important sentence in the monitoring section. Children are not static adults, they grow constantly. If a child gains 10% of their body weight and you do not adjust their ART dosage upwards, you are inadvertently underdosing them.
And if you underdose them,
suboptimal drug levels in the blood will not suppress the virus fully, and the virus will rapidly mutate resistance to the entire regimen. Managing a growing child on ART requires absolute precision.
which makes preventing the transmission in the first place so utterly crucial. That takes us to our final section, Section 7, prevention. Specifically, stopping the chain of transmission before a child ever needs those highly toxic drugs. The care protocols for an HIV-exposed neonate in the delivery room are meticulously laid out.
Let's walk through the delivery room.
The steps are: have their mouths and nostrils wiped with gauze immediately after delivery of the head. The infant must be handled with latex gloves until maternal blood and secretions are washed off. Have the cord clamped immediately after the baby is delivered and specifically avoid milking the cord.
Okay.
Have the cord cut under cover of a lightly wrapped gauze swab to avoid blood spurting. The baby must be kept warm. The infant should be suctioned only if indicated using a mechanical or electrical suction unit at a pressure strictly below 100 millimeters of mercury or using bulb suction. Mouth-operated suction is absolutely contraindicated.
Makes sense.
The infant must be cleaned with warm chlorhexidine solution to remove maternal fluids. Finally, place the baby on the mother's chest for skin-to-skin contact, allowing latching unless an alternative feeding method is opted for.
That protocol reads like a tactical manual for defusing a bomb, and in many ways that is exactly what a delivery room is for an exposed neonate. Every single step is designed to minimize the physical transfer of maternal fluids. Wiping the mouth and nostrils the second the head emerges ensures that when the baby takes his first gasp of air, it doesn't inhale the viral-laden amniotic fluid or blood coating its face directly into its respiratory tract.
And the specific instruction to avoid milking the cord. In a standard non-exposed delivery, stripping or milking the umbilical cord toward the baby is often done to push extraplacental blood into the neonate to boost their iron levels and prevent future anemia.
Right, normally it's beneficial, but in the context of an HIV-positive mother, that placental blood is a massive viral vector. If a clinician instinctively milks the cord, they are mechanically injecting a high-volume viral load directly into the neonate's circulatory system.
You're just pushing the virus straight in.
Yes, the same physical caution applies to the suctioning pressure. The text mandates keeping the pressure below 100 millimeters of mercury. High-pressure suction can easily cause micro-tears in the delicate mucous membranes of the baby's throat and airway, instantly creating an entry wound for any virus present in the mouth.
Once the baby is stabilized, the text moves to ARV prophylaxis to build an immediate chemical shield. All HIV-exposed infants receive prophylaxis. High-risk infants, whether breastfed or formula-fed, receive dual prophylaxis with AZT twice daily and NVP once daily for the first 6 weeks.
Dual prophylaxis.
If the mother is already stable on AIT, the infant receives daily NVP from within 72 hours of birth to 6 weeks. High-risk breastfed infants must continue for an additional 6 weeks, totaling 12 weeks of prophylaxis.
This is essentially putting the infant on a preemptive, preventative treatment. Even with the perfect delivery room protocol, microscopic exposure likely occurred. By flooding the infant's system with AZT and nevirapine for 6 to 12 weeks, the clinician ensures that if a few viral particles did slip through, they encounter defective chemical bricks and jammed enzymes the moment they try to replicate.
The prevention protocols extend beyond infants too. The text outlines pre-exposure prophylaxis, or pre-EP, which is recommended for high-risk individuals like serodiscordant couples, commercial sex workers, and injecting drug users using a daily dose of TDF and FTC.
Pre-EP has been a massive public health tool.
It also outlines post-exposure prophylaxis, or PP, for accidental exposure like needle sticks or assault. PP must start preferably within 1 hour and at latest within 72 hours and continue for 28 days.
The 72-hour window for PP is absolute.
Yeah.
Once the virus establishes a foothold and the integrase enzyme permanently stitches the viral DNA into the host cells, PEP is useless. You have a maximum of 3 days to interrupt that biological machinery.
We also have to prevent the opportunistic infections we discussed in the WHO staging. The text details 2 specific therapies. First, contramoxazole preventive therapy, or CPT. It is recommended for all infants, children, and adolescents with HIV, starting at 6 weeks of age, irrespective of their clinical or immune conditions.
For everyone.
Yes. Because of the high prevalence of malaria and severe bacterial infections in Nigeria, the text recommends it should continue until adulthood. The dosing is strictly by weight, ranging from 120 milligrams daily for infants under 5 kilograms up to 960 milligrams for anyone over 30 kilograms.
Okay, and the second.
Second, isoniazid preventive treatment, or IPT, is used to prevent active TB. Children 12 months and older with HIV who have no active TB symptoms and no contact with a TB case receive 6 months of IP2. Children under 12 months only receive it if they had contact with a TB case and evaluate negative for active disease.
Contramoxazole is a broad-spectrum antibiotic. It does not treat the HIV virus. But remember, the virus is dismantling the immune command center. By prescribing daily CPT, the clinician is building an artificial chemical fortress around the child to fend off pneumocystis pneumonia, toxoplasmosis, and everyday bacterial threats that would easily kill them while their immune system is compromised.
It's buying time.
Exactly. Coupled with IPT to stave off the lethal synergy of tuberculosis, these preventative therapies keep the child alive long enough for the antiretrovirals to suppress the HIV.
Finally, the text addresses immunizations for HIV-exposed children. It states they should be given all appropriate vaccines as early as possible. However, there is a massive caveat. Children with advanced and symptomatic HIV infection, meaning a CD4 count under 200, a CD4 percentage under 14%, or WHO stage 3 or 4 disease, should absolutely not be given live vaccines.
No live vaccines. This is incredibly important.
This specifically includes the BCG vaccine for tuberculosis, varicella zoster, the oral polio vaccine, or OPV, measles, and yellow fever. Instead of the live oral polio drops, they should be given the inactivated polio vaccine intramuscularly.
Giving a live attenuated vaccine to a child in WHO stage 4 is incredibly dangerous. A live vaccine uses a weakened version of a pathogen. A healthy immune system easily defeats the weakened virus or bacteria and builds a long-term memory of it.
But they don't have a healthy immune system.
Right. If a child has a CD4 percentage under 14%, their immune system is practically non-existent. Even the weakened laboratory-strained version of the measles virus or the BCG bacteria can multiply unchecked and overwhelm them. You could literally trigger a disseminated fatal tuberculosis infection by administering the BCG vaccine. The clinician must use inactivated dead vaccines to ensure they aren't inadvertently infecting the child with the disease they are trying to prevent.
We have journeyed through an immense amount of clinical reality today. We started with the sheer epidemiological weight of millions of orphan children in sub-Saharan Africa. We broke down the microscopic diploid RNA architecture of the lentivirus and unpacked the terrifying speed at which it hijacks a naive infant's immune system.
It's a lot of heavy material.
We explored the diagnostic tightrope of maternal antibodies, the grueling, toxic complexity of lifelong weight-based ART regimens, and the life-and-death physical mechanics of a delivery room. Our goal was to take this dense textbook data and translate it into the deep, practical, clinical context it demands.
And hopefully we've shown how every detail from the P24 cord to the umbilical cord clamping matters in this fight.
Before we conclude, there is a conceptual thread from the very beginning of the pathogenesis section that warrants deep consideration. The text established that the viral integrase enzyme sews the double-stranded viral DNA directly into the human host's DNA, where it resides indefinitely as a provirus.
That's the permanent resident.
Consider the profound biological intimacy of that action. In a perinatally infected infant, this microscopic machine literally weaves its blueprint into the child's genetic fabric before they even take their first steps.
Yeah.
The virus's code is written into their genome, sitting right alongside the genes that dictate their eye color, their height, and their cellular growth. If the pathogen is structurally indistinguishable from the host's own genetic material, how does that fundamentally reframe our entire medical understanding of what it actually means to cure an infectious disease versus simply managing it?